A very good afternoon to all the listeners on Health Travelers Worldwide Facebook Live. This series is on knowledge sharing about COVID 19. I am Dr. Abdul Ansari. I am the Director of Critical Care at Nanavati Super Speciality Hospital, Mumbai, and we have been managing COVID cases for the last 1 month, including all the critical patients and those semi-critical patients who have been coming to us, along with our usual hospital care. I would be more than happy to kind of talk about COVID-19 on this page, and this is an excellent initiative by Health Traveler Worldwide of getting on every Saturday 4 p.m. with some kind of knowledge sharing with experts who are handling COVID-19. So, I would like to start with a brief introduction about coronavirus, COVID 19, for all of you, and it will be very nice on everybody's part if they want to interact with us and keep on asking questions that they need to, kind of get a clarity upon. I would like to initiate by saying that COVID 19 is now entering already into its fourth month and actually has been worldwide a pandemic. Jan 31st was the day when WHO decided that COVID 19 can be labeled as a disease of real public danger, and it is a global pandemic. We all have seen nearly 2.8 million cases across the globe, which is nearly 28 lakhs, of which nearly 1,97,000 deaths have already been reported. The good part is nearly 8 lakh people have recovered, and currently 18 lakh, that is 1.8 million people, are undergoing therapy in various stages all across the globe. When we talk about India, India has nearly reported 24,530 cases so far. Practically 80 to 100 new cases have been reported practically every day, of which 5,000 have already recovered. 18,000 active cases right now have been reported by the Ministry of Health and Family Affairs. Nearly 780 deaths in India so far. We are still below the 1,000 mark. And of them, if we look at the number of tests performed in India, is nearly 5,80,000 tests so far. The sad part is looking at the population base that we are nearly doing 420 tests per million population, which is far lower than more than 5,000 tests per million population in the Western countries, including US, which is touching nearly 25,000 cases per million population. And hence, they are probably picking up more of sick individuals, and attributable mortality to COVID 19 is definitely high. We at Nanavati Hospital have so far treated nearly 115 cases of COVID 19, of which we have around 24 successful recoveries. We have lost 5 lives to COVID 19, of which 4 were 70 and above with multiple comorbidities. One was a relatively younger individual with bad diabetes and underlying bad pneumonia who presented a little late. So, moving on, this presentation would be, meant to address both common population as well as medical professionals who are listening to me. I would be more than happy to receive questions and comments simultaneously, which I can probably address. I would like to move on from this basic introduction that we are talking about the coronavirus, which is actually analog of the previous coronavirus group, the beta coronavirus group, in which the SARS virus and the MERS, Middle East Respiratory Syndrome, as well as the severe acute respiratory syndrome viruses in the past 2008 and 2012 have been prevalent, but they all never had the same transmissibility, which is really unparalleled with COVID-19. And this is the reason the spread has been really literally viral, and it has gone to these kind of epic proportions. If you look at the logarithmic profiling or the linear relationship between the timeline and the number of cases, it's actually a vertically rocketing graph, which is really alarming. The other interesting part of this disease is that the R naught, the transmissibility index, which talks about the number of cases one infected patient will kind of lead to, is a whopping 1.5 to 3.5, which is definitely very, very high, because when you look at a kind of exponential growth and coupled with a lot of international travel and the high transmissibility in common population, with population density being varying across the geographic map, it has caused such a rampant, rapid rise. In fact, it has been observed that the growth factor is going anywhere between 10 to 35%. Any growth factor of 10% is significant enough to give you those exponential numbers, which are really alarming. Coming back to the second aspect of COVID-19, why it's actually a different virus, because it has a transmissibility and a lethality, and both of them have probably made this virus really difficult to handle. The transmissibility, which we have already discussed, which is pretty high. The lethality not being very, very high. Seasonal flu has a lethality of nearly 1% and less, while this has come to a lethality of 3 to 5%. That is a case fatality ratio. I think I have two questions now, and Nishita has been asking how effective is hydroxychloroquine for the treatment of coronavirus. So, hi Nishita, that was a very simple sounding, difficult question, because if you ask me on an evidence base, is hydroxychloroquine really effective? Well, there are conflicting studies. We know that hydroxychloroquine has been beneficial in previous studies on viral replication. There is enough literature in standard medical books that hydroxychloroquine has a surprising activity against viral replication. But none of the studies have shown in real life scenario whether it helps. There have been two publications which have come, among with the latest one, which has come from the French side, has shown that it's not really effective, doesn't change the mortality, but the number of the cases included were not very, very high. Again, the dosing of hydroxychloroquine, and whether we are talking about the pre-exposure prophylaxis. So I personally would be honest that in our institution, all our healthcare workers, the frontline healthcare workers who are treating COVID-19, are given pre-exposure HCQ prophylaxis. We have hardly any breakthrough incidents in COVID wards, and we can probably draw some parallel from there, that HCQ in a very targeted population can reduce the incidence of transmission. And in vitro studies have shown that there is a good lung concentration of hydroxychloroquine even after a single loading dose, and which can last up to 7 days. And that's why the logic of giving a loading dose of 400 milligram twice a day on day one, with 200 milligram twice a day once a week for up to 7 weeks, can be a safe prophylactic dose for healthcare workers with serious exposure to COVID-19. As far as common population is concerned, I would still say that it's too early for us to recommend it to common population, but I am sure hydroxychloroquine has a long way to go. In combination with azithromycin and other antivirals, there has been a lot of evidence that it can become more effective. Now, only time will tell, and a solidarity trial, which is the trial done by WHO across all the countries combined together to see the drugs which could be of having some illustrative benefit. So only time will tell hydroxychloroquine how many lives it saved. But I think in a high risk target population, HCQ has a role to play. Vaishali Walavalkar has asked the question, how long does it take a normal person to recover from this disease? An excellent question. Again, you said a normal person. The question is, why should a normal person get COVID-19 if his immunity is fine and if he is not very heavily exposed to infection? So normal people, when they get viral infection, is just like any other viral infection. Most of them, 85 to 90%, are having mild influenza-like illness, and they usually recover within 7 to 10 days of time. In fact, majority of the times it is indistinguishable from any other kind of viral illness, and hence the difficulty in really identifying the patient who are so-called asymptomatic or mildly symptomatic carriers. So I hope that answers the question, that anything less than 10 days would be a good recovery time. I would say 7 to 8 days. Shivani Kadam, hi, is it true that most of the people are asymptomatic? Well, yes. I think this is the crux of the matter. that majority of the people can be asymptomatic carriers. They may kind of go through very small viral kind of prodrome, low grade fever, malaise, mild cough can come and go, and people may ignore it. But if you keep on testing, like US, France, Spain, Italy, Germany, where they have done nearly up to 8,000 to 25 to 27,000 tests per million population, which is a huge number, they have realized that there is a lot of asymptomatic carrier population. And hence, there was a thought that if 40 to 60% of a population gets exposed to COVID 19, the disease incidence will start falling down on its own, which is what the plateau and the falling down phase of the growth curve would be. Uh, so we are waiting more questions, and I think we are warming up. Moving on, we'll talk about some precautions. So every one of us has been reading about the social distancing, how to flatten the curve, and social distancing would be important to kind of reduce. So the very important formula which actually epidemiologists use is the population multiplied by the population density multiplied by the growth factor and those interventions which can reduce the transmission. So this is a complex equation. If you look at that, you can't change the population. You can definitely reduce the growth factor, which is dependent upon certain interventions that the population does, like hand hygiene, hand washing, covering of their mouth with face mask, and social distancing. And this would be the most important way in which you may reduce the growth factor by making lifestyle changes, and number two, separating people up. So I would actually sum it up in only a few words, that there are five important steps where you can probably contain the exponential growth of virus. Wash your hands, clean your hands very often. Sneeze or cough in your elbow. Don't touch your face. Cover your face with a mask. Keep social distance and try to limit your movements. Now, the next question is from Sana Ansari. Hi, Sana. Could it be that some patients being refused admission at hospitals and thereby losing crucial time that could be dedicated to their treatment be responsible for more COVID deaths? Well, that's an excellent question. I must congratulate you, Sana, that this was a wonderful question, as we feel that this is not different than any other viral infection. It's actually the timing, the loss of the important time when the symptoms are moving from mild, moderate to severe, or rather what we can call as a golden hour. Now, in trauma, we have a golden hour. In any kind of cardiac or neuro emergency, there is a golden hour. Nobody knows. In this kind of acute viral infection, or what is called as a SARI, severe acute respiratory illness, when does the tide turn? So if I may ask this answer, Sana, you must know that when a person's respiratory rate is going above 24, 25, you are actually having a lot of work of breathing. When your gas exchange, that is oxygen saturation, is falling down below 94% on room air, you are actually heading towards gross hypoxemia. And this is where the organ dysfunction starts. And I would give all of you common, for a very simple understanding, something called quick SOFA, which is a measure of three important parameters: any altered behavior, any drop in blood pressure, any breathing difficulty. These three are danger signals, red signals. Anyone who knows his loved one is going through any disease illness which could be mimicking COVID like illness and has any of these three symptoms needs urgent critical care, because the risk of their organ dysfunction is very high. Unfortunately, most of the time, the shortness of breath is supposed to be, oh, he is not well, he has not been eating well. They attribute to other associated factors rather than attributing it to the disease itself. So moving on to the next question. Nishita has kind of replied, ICMR is conducting trial, result will come later, but no use now in COVID-19. I completely agree. Yeah. Sanjeev Vyas, reinfection. Well, we don't know as of now whether once you have got a COVID infection, can you get reinfected? But I think it is possible. There can be a temporary immunity if you have developed the antibodies. Possibly you may not get reinfected in the immediate 3 to 6 week period, but much has to be still found about that. Mr. Uday Thakkar has asked about convalescent plasma therapy. It appears to be quite promising, but surprisingly not widely used. Well, that's a very good question. I'll tell you the reason why it is. We we are still having those people who have recovered, who are probably 14-day old, are in a state where they are probably still having lingering illness or weakness. Most of them who are not aware, they are probably not realizing that after 14 days of recovery from the illness, you have sufficient amount of antibody. Unfortunately, we don't have quantitative, what is called quantification of these antibodies as of now as a standard way. But most of us can have rapid spot tests for IgG and IgM testing. And if we know that there is a good amount of antibody in the blood, giving convalescent plasma seems to be a promising therapy. I think ICMR has inducted a couple of hospitals for doing it. A few institutions which have used it have reported dramatic improvements. I think only time will tell how improvement it is. And a word of caution, those people who have respiratory distress, who are given this plasma, can have adverse effects of plasma therapy, which should be kept in mind, including transfusion related acute circulatory overload or transfusion related acute lung injuries. Moving on, Chetna Doshi, evidence of people becoming COVID positive again after a negative report. Well, that's a very interesting question. If you look at the positive predictive value of a RT-PCR test, well, a poorly taken sample, either only nasal or only pharyngeal, because ideally it should be nasopharyngeal testing. The best possible yield could be to the range of 67 to 75%. Hence, you can still have 25% of the people who may not be coming positive on the initial RT-PCR report. But if their clinical presentation, demands a further evaluation, it is very important that you go and repeat the test again or look at an alternative imaging modality. We have realized that a CT scan is a wonderful way of picking up symptomatic COVID patients, and it has a very high positive predictive value if you go by something called CORAD classification, which is developed only for radiological assessment of disease severity. And if you have a CORAD, which is very high likelihood, that is CORAD 5, 6, you can definitely say that it is pathognomonic of COVID-19. So if an RT-PCR test is negative, but the patient is still having symptoms of severe acute respiratory illness, and your CT scan with the COVID protocol can show you bilateral infiltrates, ground glassings and crazy paving appearance or sublobar consolidation, you are essentially looking at a bad viral illness staring in your face. And it would be important to do a repeat PCR, maybe preferably 3 days later, because 5 to 7 days is the ideal time when the PCR testing can come positive. So I think a high index of suspicion for patients for severe respiratory illness is important. Moving on, Chetna Doshi had asked about evidence of, Shravani Valavalkar, is it true that if you are BCG vaccinated, you will have less severe disease of COVID-19? I'm afraid I can't give an answer with the current level of knowledge. It is possible. There is a lot of theory going on that if BCG vaccination is a potential vaccine target, and there is a possibility that it may slow down the disease process, and so is with those areas which have high predisposition of malaria. So high malarial incidence is probably also inversely related to COVID severity. Only time will tell. These are experimental, hypotheses, and they may be true. Kavita Raghu, can recovered patients get coronavirus again? I think we have answered the similar question. I don't have the answer right now, but not immediately as long as the antibody titers are good. Again, Chetna Doshi, they are clearly dedicated beds for COVID positive. But what about suspicious patients having difficulty in getting beds? That's a good question, Chetna. I will tell you how Nanavati Hospital is working currently. We have basically 3 sections. One is a suspect area. Number 2 is a COVID positive area, and number 3 is a convalescent or a recovering COVID area. So we have distributed our wards and ICUs in these 2 lines, at least 2 different distinctions. One is a suspect area, awaiting the finalization of the report or an imaging, and number 2 is a positive area. Once a COVID positive has started showing clinical response, we do repeat COVID testings. And in those 2 COVID testing, at least after 5 days of therapy, 24 hours apart, 2 reports coming negative, can theoretically be said to have completely cleared of COVID, unless he is clinically unstable. So if you're clinically better, your 2 COVID samples have come negative after appropriate treatment protocol has been applied, you can safely say that he has been cured of COVID. But still, a total 14-day of closed institutional or home quarantine under a physician follow-up is very important. At the end of 14 days, you can definitely say that yes, two consecutive COVID negative samples in a person who has clinically done well is tantamount to clearance of the viremia. And those are the candidates who can go for convalescent plasma therapy if they are healthy enough to donate. Moving on, Pallavi Naswa. Are most people with COVID 19 asymptomatic before they realize? I think we have answered yes, most of them can be asymptomatic, but I would say they can be asymptomatic for the first 5 to 7 days of the incubation period. But on the 7th to 10th day, there is a rapid evolution of disease, especially those who are having multiple comorbidities. So, especially people with diabetes, uncontrolled, CVD, cardiovascular disease, underlying elderly population, people on steroids, transplants, and malignancy. These are the people who may not predict in a predictable manner. They may have illness much more earlier, and they may have a much more severe illness presentation. So I would say it depends upon the host risk factor most importantly, and the host virus interaction will dictate how your clinical trajectory evolves. Karan Cholera, can we take hydroxychloroquine to prevent COVID-19? That's a very difficult question to answer today. Well, for healthcare workers, the risk of taking HCQ, now I don't know, all of you must be hearing about a lot of risk of hydroxychloroquine being consumed, having certain arrhythmias and probably ECG changes. So I think hydroxychloroquine is not something which is very innocuous drug to be taken without any reason. So under a close clinical supervision for those people who are high risk contacts and those people who are working as healthcare workers, there is a role of giving hydroxychloroquine prophylaxis. And as therapy, we have been using it, so we will only come to know with time what we were doing was correct and how much was it helping. So, Nazat Zakaria, can the term herd immunity apply in a country like ours? Well, yes. What are the chances of vulnerable people surviving in densely populated places like Dharavi or many such places in India? So, believe me, Nazat, life has its own way of surviving. We all should have been having much more severe. We should have a much more number of cases and much more severe cases by now, by all the predictions. We haven't seen them so far. There could be two reasons for that. Probably we are still waiting the tide. And number two, the factors that you asked about, some kind of herd immunity. There is a hygiene theory. There is an underlying kind of change in the spike protein of the glycoprotein of COVID-19 in Indian subcontinent. So enough theories are around where we all are not seeing the same number of tsunami of cases that we were anticipating. But we don't know whether we are still in the middle of the COVID storm or the worst is getting over or getting behind us. But I think there is definitely a role to play about the herd immunity. But yes, the vulnerable individuals will be the ones who would be, unfortunately, the term can be used, culled by the nature. Dhawal Kanani, how an absolutely fine looking person following home quarantine when tested found to be COVID positive. So fine looking person, well, that depends upon who is looking at. An intensivist looking at a person who is slightly breathless or slightly febrile, not looking good, may not be a good sign. While the family may be seeing that he is not sleeping well, that's why probably he's worried. So the fine looking person, the look test can be deceptive at times, because who is conducting that look test will dictate how stable or unstable that person is. I told you 3 or 4 important features, which we previously used to call it systemic inflammatory response syndrome, which will be like fever, which is high grade, breathing difficulty, fast heart rate, and low oxygen. These are the very simple parameters. And if you ask me, if the person whom you are talking to is disoriented and not coherent, is lying down, is feeling giddy and fainting, and is having a short of breath even while he is at rest, they are not fine looking individuals. As far as fine looking, what you probably meant was a healthy individual. Well, yes, we are seeing a lot of healthy individuals without any comorbidities also getting bad influenza like illness ranging into severe acute respiratory illness, though that number is still very less. Majority of the patients have some kind of comorbidity, are more than 40-45-year-old, and the majority of the ones who will need organ supports are the ones who are 65 and above. ACE and ARDS is a question by Sanjeev Vyas, a very valid question. I think there is a lot of link. If you go into the technical details, the ACE2 receptor in the pneumocyte is required for binding of the spike protein. So I'm sure ACE inhibitors will have some kind of a role. But in one of the studies, it has been very clearly shown that if you are on ACE inhibitors, you don't need to discontinue, but you don't need to initiate a new therapy with ACE inhibitor if you have a suspicion of COVID infection. So those people who are having antihypertensive drugs with ACE, ARBs, they don't need to discontinue. But yes, in any person who is having severe COVID-19 illness and having hypotension, you certainly would have stopped that medicine anyways. Janam Mehta, any precaution for private doctors practicing in private clinics? Are PPE effective in preventing? Well, PPE are definitely effective if you are wearing it with other universal precautions and following the PPE donning and doffing criteria. As far as private docs wearing PPE, I think there are very clear-cut guidelines by Ministry of Health and Family Welfare who should wear what PPE. So let me elaborate on that. A common person on the street, even if he is wearing a plain surgical mask or even a handmade mask and is following hand hygiene and social distancing, that's good enough. Is very unlikely an asymptomatic individual would be transmitting the infection. Very unlikely. And I am underlining that. Majority of the times, the infection is from mildly symptomatic individuals. So if you have mild symptom and you're hiding it, moving around, you are the most likely person to carry it. Complete asymptomatic transfer can happen while people are speaking. There are enough theories about aerosol generation while we are speaking, and that can be a cause, but viral shedding is maximum when you have some amount of symptom. So viral shedding is going to happen for a person who is symptomatic with fever, mild cough, mild coryza, mild malaise, and he is not taking precautions. So a common person wearing a surgical mask, a triple layer mask is sufficient enough, or even a cloth mask to prevent transmission to other person. Now coming to a healthcare worker, any healthcare worker who is exposed to patient population is not safe with a triple layer mask alone. If he wants to wear a triple layer mask and maintain a distance, and we are seeing a lot of videos of people maintaining OPD distances without touching them, digital thermometer, self-evaluation by patient with a shielding, possibly then it is fine. Otherwise, an N95 with a face shield or a goggle should be the minimum norm for any healthcare worker coming in close proximity to any possible COVID patient, or even any person with LRTI, because any lower respiratory tract infection could be a possibility of a COVID-19. Moving on, Sanjeev Vyas, NSAIDs. Yeah, NSAIDs should be avoided. I would personally say that NSAIDs are the single most common cause of renal dysfunction in people who have, especially they are associated with function. And I think we need to be very vigilant about prescribing NSAIDs for anyone unless we are sure that it is not in the ambit of infectious disease. Role of antiviral, retroviral. I think antivirals have been talked a lot. There are a couple of antivirals, and all of them have been junged about, except for remdesivir and possibly favipiravir. These two are not available in our country as of now. Remdesivir has shown the maximum promise. As far as the retroviral that you're talking about, lopinavir, ritonavir has been used in certain protocols, and we do use it. I'm not very sure how effective it is. So we have reserved it only for severe recalcitrant ARDS who is not responding to standard combination of medications. And I would only say that you may use it in a protocol and have an institutional guideline. There are enough good guideline material by Ministry of Health and Family Welfare. You can draw from there. And even AIMS has certain good guidelines. At Max Healthcare and Nanavati Hospital, we have a centralized guideline, which is a big 126-page dossier where everything has been covered, and we are following our institutional guidelines, which is motivated by a lot of cutting-edge research. Chetna Doshi, role of antiviral we have discussed. Mohit Talwar, I have heard most people are asymptomatic. Is that true? Well, yes. Yash Pandit, do all patients of COVID-19 suffer from cough and fever, or there are some other symptoms as well? Well, this is an important question. I would say that not every patient will have the same combination. Some of them may have only fever with mild respiratory illness, maybe loose motions or back pain, while some may have classical cough without much of a fever and very limited myalgia. What is important is that in today's world, you have to unfortunately look at the clear-cut exclusion criteria. So clear-cut exclusion criteria are no respiratory tract-like illness. So if you say that he has no breathing difficulty, he has no cough, only fever, you may be reasonably confident it could not be, but you cannot be sure because he may still be evolving. So to say to tell a person is COVID-19 is at a given point of time. The longer the longer the wait period has gone by, the more surer and more confident you can be, coupled with a RT-PCR sampling. So if you have one RT-PCR sampling for an asymptomatic patient, you have waited for 7 days, no evolution, he's practically 99% likely not to have COVID-19. Amit Dani, hi Amit. Yeah, you are doing a great job. Keep it up. Thank you, Amit. That was a nice comment, very encouraging. Thank you, Amit. Moving on to Siddharth Kelkar. Does smoking increases risk of developing COVID-19 infection? I don't want anybody to misconstrue this. So direct correlation with smoking and COVID-19 is not there, but it is commonsensical. Smoking is gonna reduce your lung immunity in one way or the other. Your mucociliary clearance is going to be low. Your carbon monoxide levels will be high. You will be hypoxemic, and you will not be well geared to fight. So certainly, smoking is a negative. If anybody wants to look it as a risk factor, yes, it can be a strong risk factor for catching severe COVID-19 illness, just like any other respiratory illness. Deep Meta, can't it relapse? Well, it can. So it's a virus, it can always come back. You can always say that you have immunity. I don't know how long it lasts, whether there are some sero changes. All these questions, National Institute of Virology is working on, and we don't have any consolidated data yet. Pranav, there is a COVID positive case near my area. Is it possible to spread in the locality? Well, we are seeing only this all across. So yes, this is a real life scenario that if there is any person who is COVID positive in your locality, in your building, in your family, you have to be vigilant, and you have to report it to the civic authorities. And don't create panic. Don't create. Maybe he is just transmitting it. Just make him wear a mask, get him tested to the appropriate facility, and take help of the epidemiological cell and the Ministry of Health and Family Welfare and the local authorities. They are really going out of their way to help you out contain the disease. Any help stem cell in COVID-19? I have no idea. This is a very difficult question. I can share on this platform that we were in touch with a prominent stem cell research company who had reached out to us that there is some therapy which is going to be beneficial, but I think it is still off-label and there is no proven efficacy recorded. Siddharth Kelkar, does HCQ help in preventing COVID-19? I think yes, but it's a personal opinion. There is no scientific, backing, very strong or robust scientific backing as of now. Will herd immunity help the nation? I think these are certain questions which we have already answered. Will herd immunity help the nation recover faster? Certainly yes. Rash on toes as a new sign of COVID. Acral rashes is supposed to be one of the presentations, but I don't think it is a pathognomonic presentation. I would rather say that when you are having an advanced microcirculatory dysfunction in any viral illness, you can see acral cyanosis or livedo reticularis and a few more signs which can be seen. I'm sure this is more for doctors rather than the common people. Sanjeev Vyas, what symptoms do we focus for in coming months till we reach herd immunity in family? I think it's the same basic. You have to look for the same influenza-like illness. That is influenza-like symptoms like fever, cough, coryza, body ache, and respiratory symptoms. They would be very, very important. Apart from that, I think in the presence of a fever and a backache and no respiratory illness, you have to keep a close vigil. That is this gentleman going to evolve into a possible COVID-19 scenario? So I think we need to have a heightened sense of vigilance, but no panic. Siddharth Kelkar, why COVID-19 not so much seen in pediatric age group? Any specific reason for it? I don't know any specific reason, but I think we can celebrate that. So kids are kind of really in all across the globe. The involvement of kids is hardly heard of, and probably there is hardly any mortality for children below 9, at least not that I am aware of. So that's something possibly because of some kind of poor pneumocyte affinity. I'm not the right person to give you an answer on that, but there are a lot of hypotheses for that. What are the prognostic indicators? Well, so prognostic indicators, very simply, if you put down, that's a very scientific question. I would like to answer scientifically. that if you have starting prognostic marker like very high LDH, very high TROP-I on the presentation, very high CPK, very poor PF ratio, altered mentation, distant organ failure, they all are bad prognostic markers. I don't know whether you would be aware of, there is a very nice score which we all intensive care personnel use called sequential organ failure assessment. And this is a detailed assessment about all the organs, brain, heart, lung, liver, kidney, and blood. So if you have any person who is having an altered behavior, restless, agitated, that's a bad sign, poor prognostic marker. These are clinical poor prognostic markers. Number two, if your gas exchange is poor, that is your saturation is below 92% on room air, and your respiratory rate is more than 30 at any given point of time, they are bad markers. If you have a blood pressure which is dropping down for a person who is otherwise normotensive and below 15 to 20% of your baseline blood pressure, that's a hypotension. That means if your BP was always 160 by 90 and today it is 120 by 70, I am worried. I am worried for you because your blood pressure is lower than your usual. So that's something which is worrisome. Liver dysfunction, renal dysfunction, decreased urine output or jump in creatinine or doubling up of creatinine is called acute kidney injury. And finally, dropping platelets or dropping WBC counts. There is one more interesting term for doctors, neutrophil and lymphocyte ratio, and that can also give you an idea. More than 3.9 is actually a poor marker. So I think a lot of prognostic markers clinically as well as biochemically are available, and ferritin is also one level. Ferritin and LDH levels we are doing regularly, and on advanced centers we are doing interleukin 6 level, which can give you an idea for using other therapies to mitigate the cytokine storm. There is something called CRS, cytokine release syndrome, which is the reason for an overwhelming host response against this viral infection, causing distant organ failure. Moving on, I think, do healthcare worker have a higher viral load? Well, yes, logically yes, because of the environment in which they are working. Though it's not supposed to be airborne unless aerosol generating procedure is being done. So for common people, AGP, aerosol generating procedures are like suctioning, like physiotherapy, like nebulization, like intubation, bronchoscopy, endoscopy. So these are aerosol generating procedures in which the amount of viral shedding is very, very high, and it is no more a droplet spread. A droplet spread is limited within a meter's time, and this droplet will have a particular size and it cannot travel beyond a distance, and hence we say that zero point 0.3 meters would be a reasonable distance, and on a safer scale 2 meters is a very good separation, a spatial separation in which the droplets cannot travel. But an aerosol is an entirely different way of transmission. If you have a cough and suspended air particles, which are aerosol, they can stay in an environment for 3 to 4 hours. And in an environment where there is poor ventilation, there is no negative pressure generation, and the air is not recirculated more than 10 to 12 times in an hour, the healthcare workers would be exposed to those viral particles. And it has been shown that the maximum severity of illness had been seen in healthcare workers because they had high viral load, or what is called the high viral quantum exposure. And this can probably define a very short incubation period for them. And they are many of them are already on HCQ prophylaxis, hence they may probably beat the HCQ barrier. Amit has a question: when COVID-19 positive patient has been treated, then how often the COVID-19 tests are done, and after how many negative results patient can be discharged from the? I think I answered this question in the beginning, but again, just to kind of, for the sake of brevity, I would say that from the day the COVID-19 swab is positive and the patient is hospitalized, at least 5 days of therapy should be given before a repeat sample should be done. And after the first repeat sample is positive, after 24 hours you can repeat another sample, and consecutive two negative samples and a clinical improvement can be a good starting point. But there are exceptional reports of even third, fourth, ninth samples coming positive repeatedly, which is poorly understood. I think it is about something to do with the host viral clearance. And in our institution, we change the antiviral that we are giving or change the therapy protocol. Tocilizumab is one therapy which can probably be helpful for those people who are not responding or who have got poor viral clearance, which we have been studying, and we have seen a reasonable response in a limited number of cases. Sheila Rathod, 36-year-old doctor with no comorbidity, succumbed to the disease. Can you explain the reason for this? I really don't know, Sheila. This may be because of poor presentation. I think some kind of high viral load, or maybe it's a drug-induced adverse reaction. It's very difficult. It needs to be evaluated completely by a set of people who can look at various aspects of this mortality. Can you elaborate on neutrophil and lymphocyte ratio, please? So, well, in all viral illnesses, there is leukopenia. The WBC counts fall down, but a neutrophil lymphocyte ratio is something which is kind of found to be very early predictor of viral lymphopenia. That is, your lymphocytes, which are supposed to fight these viruses, are not coming up, not rising to the occasion. So bacterial infections are fought by neutrophils predominantly. Viral infections are fought by lymphocytes predominantly, and there has to be a ratio. It's just like the Army, Navy, and Air Force ratio. So if you have more of neutrophils fighting the battle with low general leukocyte count, which means your viral fighting force is actually overwhelmed. Your lymphopenia is actually not allowing you to fight the virus well, or the virus load is very high. I think that's how I will interpret. I'm not the best hematologist to kind of comment on that, but any neutrophil lymphocyte ratio which is more than 3 or 3.5 suggests that there is a relative lymphopenia, which is a bad sign. Nazar Zakaria again, is it safe enough to wipe down door handles, grocery bags with Dettol solution, or does it have to be only an alcohol-based sanitizer? Well, I think Dettol, I'm not very sure about the content of ethyl alcohol in that. So at least 65 to 70% of alcohol is important, or 0.5% of hypochlorite solution. They are the two recommended ways of sanitizing. Alcohol-based sanitizers are good for animate objects, and inanimate objects should have chlorine-based washing. So I would say hypochlorite-based solution, or 5,000 ppm of active chlorine in the sample should be enough. There are enough sanitizers for surface cleaning as well as hand cleaning available in the market. So I think we have taken a lot of time. I must request everybody to who is interested in kind of increasing the public awareness, to come into this novel platform by HTW, Health Traveler Worldwide, where they will be inviting frontline doctors every Saturday 4 p.m., where you can have a good interactive session. And I think knowledge dissemination is the most essential part of this fight against COVID-19. Knowledge power long back, and I think it can be more today. I have a comment from Sana Ansari. Hi Sana. Arundhati Roy speaks about learning from the destruction of this disease and reimagining our world and systems anew. As a stellar IC especially in the throes of the disease and its management, what would you say is a vital take-home lesson for the medical fraternity and governments alike? Where can we assess and recalibrate on individual, state, and national level? A very loaded question. I would say we all are learning. We all are human. This virus has told how what a speck of dust we are in the universe, and how humiliated we are and how we are by this viral illness. And we must learn that together we can, and we need to collaborate rather than hide or kind of brush under the carpet the learnings. We have learned in the past that zoonotic diseases could be a disaster, and this has been told right in 2012. And in fact, 2018 was a centenary celebration of the Spanish flu, which nearly wiped out 1/5 of world population in 1918. And 2018 was a time when the first time a disease X term was coined by the WHO Task Force, which was talking about a future disease X which can wipe out a large chunk of population. Believe me, COVID has very, very quickly fit into the bill of a disease X, where the global health resources, policy makers, administrators, frontline healthcare workers all need to work together rather than exclusively. They have to be all inclusive. They have to learn, share, and probably disseminate the knowledge. Thank you very much for a patient hearing and for making it such an interactive session.